Good evening, everyone. Today I'll be presenting on the induction deaths in acute lymphoblastic leukemia and analysis from a low middle income country. So, cancer outcomes in low middle income countries lag behind the Western world. TRM, that is treatment related mortality, is the biggest impediment which affects a good cancer outcome. So IPO-MCG definition of TRM is death occurring in the absence of progressive disease. While developed countries document a TRM of less than 5%, ranging from 2 to 4%, with an overall cancer survival of up to 90%, here in India, the so far published studies document a TRM of 11 to 26% with a survival of only 40 to 60%. So why this high mortality in LMICs? This has been attributed to lack of supportive care, non-accessibility, non-affordability to high-end antibiotics, comorbidities, mainly undernourishment, access to timely care, lack of shared care, poverty, and death from toxicity, in addition to the relapse which always affects a poor cancer outcome. However, over the years, we have documented a declining induction death rate in our center. In the 1990s, while the induction death rate was as high as 21%, now it's dropped to 6%. And this was possible because of improving supportive care, a uniform protocol, and better risk stratification. Also, prophase steroids, which has helped in a gentle cytoreduction and stabilization in the initial phase, has helped. So, aim of this study was to analyze the cause of deaths during induction therapy in patients with ALL at our center. So, our center is a 2,240 bedded referral center in North India. We cater to 4 of the surrounding states, and patients within a radius of 300 to 400 kilometers mostly come to our center. We have a 250 bedded pediatric hospital with a dedicated hematology oncology unit, and we cater to 450 new oncology patients every year. So in this, a retrospective analysis of induction deaths from 2018 to 2022 was performed from case records. Therapy was as per the Indian Childhood Collaborative Leukemia Group ICICL protocol, and in this the patients were risk stratified into standard risk, intermediate risk, and high risk based on age, immunophenotype, cytogenetics, response to induction therapy, bulky disease, testicular involvement, CNS involvement, and prednisolone response. So in our induction protocol, patients who were deemed standard risk received 3 drugs, which were steroids, vincristine, and L-asparaginase, and if intermediate risk or high risk, they additionally received guanosine. And it would be just 2 doses if they were intermediate risk and 4 doses if they were high risk. TALLs were managed as high risk. So we initiated 742 patients on ALL therapy in these 5 years. 84% were BALL, 13% TALL, and mixed phenotypic acute leukemia in 3%. While high risk group composed of 44% of the patients, standard risk were 32% and intermediate risk 24%. So in this time period of 5 years, we noticed 47 deaths in the induction phase. Males and females were almost similar. While we had 40 deaths in BALL, 3 deaths in T, and 4 in mixed phenotypic acute leukemia. So we realized that the biggest cause of death overall are the infections. And while 32% of the patients died in week 2, within the first 2 weeks of induction therapy, we had 68% deaths in the late phase of induction. And in both early and late phase, it was infections which was the main killer. So when we studied this profile of infections, we found that most deaths were due to bacterial sepsis, in which gram-negative bacteria were most commonly isolated. 76% were bacterial deaths. While no organism could be isolated in 6 patients, there were clear evidence of bacterial sepsis. We had proven or probable invasive fungal disease in 15% of the patients. Other causes of mortality included major bleeds, and this was the second most commonest cause of death. Though we had 4 patients in whom we could not ascertain a cause, it was most attributable to sepsis. Then we studied the mortality across risk group, and as is clearly evident, high risk had increased number of deaths. And this was a statistically significant association. We also adjudged if other factors like bulky disease or hyperleukocytosis had increased deaths. We found that bulk of the disease probably did not have increased deaths, but there was increased deaths when the patient presented with hyperleukocytosis. However, this was not a statistically significant association. So, in conclusion, we had 6% induction deaths, with 3/4 being attributable to sepsis. Thus, superior infection control and prevention practices to improve overall survival is definitely the need of hour. And bacterial sepsis overwhelms, with gram-negative bacteria being the commonest causative organism. Also, high-risk disease is a definite risk factor for induction death. While hyperleukocytosis and bulky disease was associated with increased death, this was not a statistically significant association. Thus, the compelling need of the hour is to ensure excellent supportive care, including adhering to the golden hour in surviving sepsis.